General Summers, let me ask, based on your presentation, can you tell us all what types of exchanges? You mentioned NAG. I guess people in the National Association of Attorneys General don't like to be called NAGs. But what form of a conversation from state to state exists among attorneys general on issues like this to protect their constituents?
They do call themselves NAG. And also, like NAAG, National Association of Attorneys General, or National Association of Aspiring Governors.
But not in Delaware.
That's right. That's right. Not in Delaware. You would be pleasantly probably surprised about the bipartisanship that occurs on issues like the one that we're talking about within NAG. Now, it's true that NAG has taken a shift from nonpartisanship or bipartisanship to somewhat partisan about 10 years ago, maybe 12, when they formed the Republican Attorney General's Association, RAGA, and then naturally what came later, DAGA. And so, but when something like this happens that affects Tennessee the same way it affects Florida, the same way it affects Colorado, the same way it affects New Jersey, then they get together and they literally, what they do is they will set up national conference calls. They will have a team of lawyers from whatever division that particular subject might be to get on the phone, including the Attorney General, and they will talk about how or whether NAG should take a general concerted effort in either opposing or proposing whatever the issue might be. I'm sure, of course, I wasn't involved in these conversations, but I'm sure that probably took place at some point in time before the letters came out. You'd be very pleased that that process works, and it works on a bipartisan basis.
Thank you, General. I want to make one concluding comment, and then it's time for discussion and questions among those here. I think Bill Young said something that was important. I touched on this in my opening comments. The thing that's so troubling about the national health care debate is there's an element of kabuki theater here where the real underlying issues are never really addressed or touched. I mean, it's one of the more frustrating things. There's a lot of bomb throwing back and forth, from IEDs to stink bombs, and there's lots of collateral damage that comes from this in our political process. But the key question is how we think about medical care. And Bill talked about entitlements. I talked about social insurance versus a market-based good or service. If we think about healthcare as a market-based good or service, the issues are pretty straightforward. That is to say, do we think that the market approach is enough? And most of us don't. Is it a good way to start? Yes, it is. But the question in any market is, markets don't redistribute income or wealth. And so the question then from a market-based perspective is, what's the appropriate level of redistribution of income and wealth? Who gets it? How do you qualify for it? And who pays for it? They're very simple issues. And to what magnitude? And then you have to begin to define what you're entitled to. Governor Bredesen in the state has really been a pioneer in defining what the scope of the entitlement is in a way that we have, the governor took a lot of criticism, but it's had great effect. And that is that there's an economic dimension in the definition of the entitlement in TennCare. And many of us took lots of heat on this issue, and the general knows about these conversations. And that was the statutory definition of medical necessity. And the medical necessity definition in Tennessee is not that you get all beneficial care, but that you get the care that is adequate for the diagnosis or treatment and is the least costly alternative. Now that is a different strategy, and ultimately that suggests that there are limits on what the scope of the entitlement is. So who gets the benefit? Those who are eligible, but what do they get? Not just what the doctor says, not just if something is better than placebo. It's if it's the least costly alternative. That means if you can do a procedure inpatient or outpatient, and it's adequate to do it outpatient, it's less expensive, all the government will pay for under TennCare is the outpatient procedure. If you have a headache and it costs a penny to get an aspirin and it costs a quarter to get a Tylenol, you'll get the aspirin if it's adequate. And so that is an important breakthrough. It requires consideration of what the scope of the benefit is, and it's something that it's a conversation we haven't begun to have on the national level. Last point, what's this public option debate about? I mean, this is one of the most frustrating conversations because the real issues are not really ever discussed. We think about market goods in a very different way than we think about public service. So think about trash collection. Trash collection is a public service. It's offered by the government. And the key there is that the relationship between payment and receipt of service is severed. In a market, there is a clear relationship between payment for and receipt of a benefit. If you don't pay, you don't get it. And so the strategy, the agenda of many folks is to transfer medical care from a market good, there's a relationship between what you pay and what you get, and trash collection. It's to turn medical care into trash collection. So if you happen to pay, and everyone in this room probably pays a higher level of taxes than many other folks in Nashville, but if you say, I don't really think it's enough to have 1 day a week backdoor pickup, I want to have 2 days a week, and you say, I pay more taxes and I should get better trash collection, you'll go down to your council member, you go to the mayor, and they'll laugh at you because you're a taxpayer, and all taxpayers are treated the same. It's the solidarity principle. And if medical care becomes like trash collection, then the claim of linkage between what you pay and what you get is eviscerated. And that's the agenda for many folks. That's the goal, is to transform medical care into an entitlement, a social insurance phenomenon rather than a market insurance phenomenon. And as more people go into the public sector, it's easier to see it as trash collection rather than a private sector market service. And so it's ultimately what degree of egalitarianism is appropriate. And the key difference with respect to trash collection is that if you want to buy a second day, you can do it. The problem in medical care is it's so expensive, there's so many impediments, and under the Clinton plan, which was not adopted, it was a felony to do that. And so I think that becomes the issue. What is the supplementation option? What is the option to go outside the service? And if the service is defined as medical necessity under TennCare, there are a lot of folks who have BlueCross or other United or other comparable provisions who are not going to be happy with the TennCare definition. And so it also raises the question of whether we can have multiple tiers of service or not. And that's an ideological agenda. If you're not ready to accept multiple tiers, then you have to avoid them and do away with the private market. Because if you're going to have a private market where there's a link between what you pay and what you get, there are going to be multiple levels of service. And I think the honest question is, what's the acceptable degree of difference that we're willing to accept in our society? I think certain areas like life-saving care, if Bill Gates and a Medicaid mom are in a crash on the highway, I think we all would want them to get the medical care in accordance with purely medical criteria. Money shouldn't be the object. But an aftercare on something like rehab, does it offend our sense of sensibility that Bill Gates is going to be able to have the therapist come to his house, and the Medicaid mom's going to have to show up at a clinic somewhere? And that's the reality. Is that an acceptable level of difference? So will we willing to accept that within our society? So the question is, what's within the core of egalitarianism and what's not? But we haven't really begun to have the conversation. That's the real question. And we're not willing to talk about that. Haven't been so far.